Let me ask those who have questions. There are mics on both sides. If you'll line up, I would ask you to identify yourself, and I would ask that whatever you say ends with a question mark, so that we can, and there's a lot of interest and a lot of folks we want to get through as quickly as we possibly can. Let me begin with Dr. Kellerman.
Kellerman, obviously we have a lot of engaged people out here. Quickly, you all talked about a lot of topics. You talked very little about technology, which is clearly one of the dominant drivers of increased healthcare costs in the U.S. But today, if Peter Orszag invented a $1-a-day pill that could lower the risk of stroke and heart attack in this country by 50%, he could not find any investors to put the money to bringing it to market. I didn't see anything in these marvelous reports about that powerful policy lever. How can we incentivize innovation in American healthcare technology the way it is incentivized in so many other domains of the American economy?
Well, Peter might get an investor, but would any of you like to comment?
Yeah, look, I mean, I think one of the promises of the alternative payment models, if patients are sticky, and this is the problem, that there's much less incentive to invest in something that will pay off over 10 or 15 years if that beneficiary is not going to be with you. But in structures where the beneficiaries are kind of sticky, having one entity that's responsible over a longer period of time helps to create exactly the incentives that you're talking about. So it's not a perfect solution, but I think it sort of is a evolutionary solution, or not solution, but approach that helps to create better incentives. And actually, I know we have tons of questions, but really quickly, because one of the other questions that came up, allowing the secretary to negotiate drug prices, in my opinion, I was asked this question as CBO director, would do almost nothing. And the reason is that she doesn't have a formulary and she doesn't have the ability to set the price. So just quickly on that front on innovation, at some point I think pharma is going to say, please don't throw me in the briar patch, accept this leading proposal from both sides, and it would have almost no effect.
To my left, and I would note, having recognized Art, the one thing we haven't touched on is workforce, which is one of the critical papers, and I would want to bring everyone's attention to that as well. We didn't have a chance to, but on my left.
Right, thank you. That's exactly the topic that I'm going to ask you a question about and make some suggestions. I'm Kathleen Blake. I'm with the American Medical Association, and one of our strategic initiatives is in the area of accelerating change in medical education. And part of what we have learned as we have taken a deep dive into that is that we do need to retrain the workforce, or the way that we train individuals going into the practice of medicine. And we're soon to publish a book that has to do with healthcare science delivery system learning for both medical school faculty, who frequently know very little about this, but also for medical students. So if we take that, but the concern I want to talk about is, do we have the right mix and the right educational levels across all of the healthcare professions? And I think now about how a doctoral level degree is currently required in pharmacy, often to work in a hospital, increasing numbers of doctoral level nurse caregivers, and my daughter, a physical therapist, who is required to have a doctoral degree to be able to practice in the state of California. So as we keep raising the educational levels that are required, are we going to get the workforce that we need and want in this country? And during those additional years of education, you are piling on educational debt, which is a problem. Think of that as money that the healthcare system will need to pay back for those individuals. They will need to earn the money that allows them to pay back their loans. So I think we need to re-examine what the different tiers and grades and mix should be. And then I would point to what I see as a looming problem, which is that many of us received our education at state-sponsored educational institutions, universities. The contribution financially by the states to their universities is at an all-time low. They now account for about 20% of the budget at a state university comes from the state itself. So the cost of education per year is going up, and I think we should regard that as a problem in healthcare.
Let me ask Rick and Lou very quickly to comment on the sort of medical education issue. I would note, Deb Trotman's here, there are other of my nursing colleagues here. The issue is one that's confronting nursing as well, although in nursing you don't have the kind of federal support that you do in medicine, which is not insubstantial. But let me ask, either of you have a comment on the sort of workforce issue, what we need going forward?
We need a different workforce. We need everybody practicing at the top of their license and training, and I think that there's a natural inflationary kind of sensibility that the professional organizations tend to have, and I hope that through alternative payment models we'll actually find the way to right size and right level the folks we need. I think those are great points.
Yeah, Kathy, I think I agree with Rick, and your comments are spot on. The AMA is doing great work to reform medical education, and I think one of the things that I see, it's in the area of new relationships, the whole concept of interprofessional collaboration, interprofessional education, and then in terms of policy, basically, GME, my opinion, ought to have more focus on performance and making sure it's performing as a public trust along the lines that have been suggested, and particularly supporting new models and new competencies.
I would add that the way Medicare finances both medical education as well as how we pay for physician services, and this question of, we used to call it cognitive versus non-cognitive services, which the orthopedists never appreciated, but the whole movement towards primary care services and how we incentivize that, I think is fundamental. Peter.
I was going to just say, look, two things. First, I'm personally very encouraged by the medical school curriculum reforms that are happening. I mean, the Dell Medical School, the Harvard Medical School redesign, I mean, there's a lot of positive movement. The other area where there's been some movement, but I think there can be a lot more, is on recertification and how we how you update your certificates to put much more emphasis, which is the direction that things have been moving, but much more emphasis on actual practice and a little bit less on the, if we're recertifying a driver, I'd care much more about how many accidents that person had and a little bit less on whether they, can pass a written test to park 10 meters away from the stop sign.
Good. To my right.
Yeah, I'm David Sklar from University of New Mexico, also editor-in-chief for academic medicine. And I just want to follow up a little bit on the issue of medical education, because I think that it's one area in the report that maybe could be beefed up a bit. And we've just talked a little bit about the how many and the mix of people. We haven't talked too much about the what. That is what we actually teach our students. And I think there's a reason for that, and that is that mostly in medical education, our students are preparing themselves to take tests and to be certified and so on. And most of those tests really are focused on what we would call medical knowledge, and very little on cost of care or management of high-risk populations. So question to the group is, what can we do through payment incentives, whether it be through governmental or through other kinds of incentives, to kind of help shift some of the emphasis and bring together the education world and the care delivery world so that they are better in line? Because I think right now they're sort of somewhat separated and not very well aligned.
Payment, Rick?
I got an email from a former colleague who's quite a bit younger than I am, who is in his second year in medical school at a large East Coast medical school, and he said, I'm texting you, it was a text, from the first class in the history of this university's medical school to teach quality improvement techniques. This was this fall, right, just a couple weeks ago. So, I mean, I was happy to hear it, but blown away that they're just now getting to that kind of a curriculum. And, I guess I'd wondered, a lot of that education is financed by state and federal dollars, and I would wonder if there shouldn't be an expectation about training. And again, I don't want to urge the government to go real deep into setting curriculum, but I guess I wonder if there's a mechanism to get to that. It's hard for us, I think. Well, Lou can speak to the likelihood of insurers wanting to pay downstream medical costs or education costs for forthcoming professionals, but I just wonder if there maybe it's more of a social issue. And I don't know, why is it so hard for medical school folks to actually understand that we need to start training people differently?
Yeah, I guess my take is, in talking to the current generation of students and residents, what I hear from them is, we know we need this curriculum. Actually, our faculty don't know it. There's a kind of a bottom-up, and in some is work that the ABIM Foundation has funded that essentially has been a kind of bottom-up movement by students and residents to develop curricula around quality improvement, cost effectiveness, and I agree with Peter that some of the new medical schools will be architected differently, and that's very exciting. Probably the most important thing, I think, for academic medicine at least, is for the faculty to actually have some actual experience in a highly performing care delivery system. Then they would know it so they could teach it.
I think it's also critical that we've begun to acknowledge and encourage training that occurs outside of acute care institutions in the community. This is true of both medicine and nursing. So there is a movement in terms of how we recognize that teaching occurring, but I think there is this generational issue, and that is the extent to which the generations are changing and the training is changing as a result of the generations. To my left.
Yes, great presentations. My name is Jay Gershon, and I serve as president of Northeast Ohio Medical University. So we have, with the allopaths and the osteopaths, about 150 or so academic health centers in this country, and we do a pretty good job in incentivizing our graduates to go into well-to-do neighborhoods, and need to continue to do that. Well-to-do neighborhoods deserve a good workforce. But we're really challenged with regard to incentivizing our graduates to go into underserved urban and rural communities. Another slice of workforce, in addition to the number of the mix and the things you're talking about, primary care, excellent points, is the distribution of the workforce and the diversity of the workforce. I believe the ACA has two major workforce provisions. One is a commission. I don't think it's been activated.
Was not funded.
And secondly is National Health Service Corps dollars, right, which is nice, but it's a loan repayment program. It doesn't really link to communities except for the communities that are served, and then of course the providers leave those communities to go home. Getting back to White House recommendations, what might you recommend regarding how to beef up the ACA to address a lot of the issues that you just heard about diversity, about distribution, about mix, about practicing, in underserved communities and so forth? Because I think unless we address that, we're just going around in circles. We're never going to get to where we want to go with regard to the number of providers needed and the kinds of providers to do all the things that all you were talking about.
I would add two things that were also in the ACA. One was the creation of a teaching center program that was funded with the intention of moving people more into communities. In addition to the bump up in the National Health Service Corps funds, there were also a program for the training of graduate nurse practitioners and increasing, again, the opportunities to go into the community. So I think there were a number of things, and the question is how effective they've been, which is one of the questions that's being asked currently.
Yeah, the other provision in the ACA was a requirement for qualified issuers to contract with FQHCs and
correct,
essential community providers as well.
Right, and a big bump up in community health center funding as well, a couple of $2 billion. So there were a number of changes. Mike, Chernow.
Just one other point.
Sure.
I think it does go back to selection also, about what is the process that we use to select folks to go to medical school, to go into advanced nursing programs, and is there an opportunity for us to look for folks who are much more likely, I think, although I don't know the numbers on this, but
to stay in their communities.
To stay in their communities, and it would seem to me that's another avenue here. What's interesting is, despite the escalation in debt and the opportunity to get forgiveness of that debt, we haven't seen, I guess, that hasn't solved the issue of understanding underserved communities, because the income opportunities are so dramatically greater in specialists in dermatology, radiology, anesthesiology, et cetera, that folks are just, foregoing the opportunity to eliminate their debt. So
Telemedicine.
it seems to me that there are opportunities there. I'm not expert enough to know exactly what to
There are some,
recommend.
the question is spot on, and particularly in rural health, there are a lot of opportunities. Our Center for Health Reform and Modernization did a report on rural health a few years ago, highlighting the access challenges, but also the opportunities relating to telehealth, issues relating to scope of practice. If you could basically have everybody practicing at top of the license, you would build more effective capacity. So there are things that can be done and could be augmentations.
Mike.
Hi, I'm Mike Chernow. I'm the Schaefer Chair of Healthcare Policy at Harvard Medical School. I say that in case Len's listening online. You mentioned a lot about chronic conditions and high-cost, high-needs patients. Currently, in the Affordable Care Act, the term prevention excludes important secondary prevention services for patients with chronic conditions, many of which are quality measures by NQF and other places. And there's a series of regulatory barriers that prevent the flexibility of plans, MA plans or high deductible plans, for example, to protect those patients in accessing those services that NQF and others would agree are the important services. My question is whether or not you see that as an important problem and whether there might be some there's likelihood that there might be some regulatory flexibility in allowing organizations that want more flexible designs to protect patients with chronic conditions from the services that we all recognize they need to take from the increasing financial burden they face as cost sharing, as you've all mentioned, is inevitably rising.
I would say a growing consensus that that's something that needs to change, and I think there's a lot of opportunity to address it, but you're putting your finger on something that's critically important. For people with complex chronic conditions, they are finding themselves, if they are of lower to modest socioeconomic status, often being in a situation where they are out of the healthcare system for purposes of issues that would help prevent the worsening of their condition. I think there's an opportunity to do that. I think the way the politics play out over the next couple of months will help define that. But I'm hearing a very strong, growing cry from the patient community and all stakeholders that there's an opportunity there. One of the things we look at in our sector is how do you bring all the stakeholders together to identify the problems? It's easy for us to say, the big bad insurance company is preventing us from access to care we need, but the reality is they're dealing within an environment, a set of constraints that make it hard for them to do what we would like them to do. So it's time for us to come together and solve the problems collectively rather than just trying to squeeze that bubble and fight each other.
Yeah, Mike, I think there are opportunities there to think about policy and regulation. The other one that your question brings to my mind is around the issue of expansion of HSAs. HSAs now are tied pretty narrowly to high deductible health plans, but talk about something if you thought more broadly, and she'll ask a question about tax treatment and so on, looking holistically about having tax favored resources available for people for a wide range of uses and a wide range of benefit designs might also be something to think about going forward.
We have about 7 minutes left, so we're going to do a lightning round, short answers, short questions. My gentleman to my left.
Two quick things. One is, I think the pain issue is a very instructive history about how clumsy policy application is and how unintended consequences always occur. The conventional wisdom in the 70s and 80s of all the experts was that we undertreated pain management, and that was true. But what happened since, I think, is many other influences. I want to ask a quick question, though. I'm Joel Coopersmith, and I'm the Director of Veterans Initiatives at Georgetown University. I'd like to ask, on one hand, everybody thinks, quite rightly, that we need a patient-centric healthcare system. And on the other hand, everybody agrees that we need more data. What are the rights of patients as to the use of their data, and how do issues like that play a role in what you're discussing?
Good question. Patients' rights.
I think patients have the right to their data and to their medical record, et cetera. I think it can be. I think it can be scary at times, depending on how uses of data are laid out to patients. So that in the ACO work that went on and lots of the data work around ACA, we sought opportunities for patients to have the opportunity to say no, but did not set that as the default situation. And I think that's an important reality, so that not hearing from patients, it's okay for us to go ahead and do all those things that we believe are enhancing care and providing more care coordination. So that's been a big issue. I think we need to be responsive, but I think we also don't want to create constraints that allow us to actually better understand a patient's circumstances and our ability to try and help them.
I want to underscore, the patient community has long felt that there's a paternalistic approach to data. We certainly want it protected, we want it safe, but at the end of the day, we want it used to make interventions and delivery systems better. I think this is a perfect opportunity to engage the end user in the development of policy around data. We're very involved with a report that came out with IOM not too long ago, actually it was fairly long ago, 7 or 8 years ago, on data. We've finally started to see some of the implications of that brought to the fold, but the reality is that most people want their data to be used. The thinking around it is very, very different than it was even 10 years ago. But if you engage the end user and develop policy around that, I think there's an opportunity to free up data in a way we haven't, while still protecting it and allowing some people to opt out. And you're absolutely correct. The default button should not be that you can't have it.
We've been given a reprieve a few more moments, so let me go to my right.
Great. I'm George Mensah from the National Heart, Lung, and Blood Institute at NIH. And I just wanted to say this has been a truly fantastic session, one of the most thought-provoking and most informative sessions I've attended in a very, very long time. So I really thank you.
Well done.
I have a very short. This is extremely thought-provoking. So my question, and by the way, I loved the elevated speeches, both the long versions and the short versions. But what I really liked about them is, for many of them are very innovative, but truly we don't know how best to implement them, and especially how best to take them to scale and how best to spread them. So if the new administration says, this is great, go ahead and do it, we honestly don't know how to do it well. So for part of the executive branch that represents the research funding agencies, what advice would you give in terms of taking some of these through implementation research, where rather than just doing it, we do them in a rigorous way so we can learn from the outcomes and be able to improve, much like in a true learning healthcare organization. And also maybe for the rest of the day, if you could just spend just a few seconds and give some guidance as how we can do this in the real world and learn from them and improve on a yearly basis rather than just doing it. Thank you.
Thank you.
Let me comment on this, because I think it also highlights the comments that came up earlier about stultifying policy, where you put something in place and then you can't move. And that absolutely has to change. By the way, it's not just in healthcare, pretty much across the board. The federal government in particular does a very poor job of evidence-based adjustments to ongoing programs, which is what we absolutely need. I would say much of the most maligned parts of the ACA were designed, despite the way that they're presented in public, to help facilitate exactly that. So the CMMI flexibility, the IPAB, great example, the IPAB. The IPAB is presented publicly as if it's this, death panel killer thing that somehow was designed to punish evil providers or what have you. I can tell you, I know this firsthand, the president's motivation in pushing that hard was the hope that it could become the avenue in the face of a polarized legislature for faster feedback loops as we learn things and then move to scale to implement them. If you actually look at what he has said about it, that was the purpose. It's not the way it's presented, but it was designed to provide a more facile kind of feedback loop than the prospects of having to go back for new legislation in many areas, which is where we are along many dimensions, and that just looks very, very daunting right now. So it's hard to have a intelligent learning system when there's a key impediment, which is that you have to get bipartisan agreement in a deeply polarized political environment at each stage. You're not going to get that rapid feedback loop going.
Rick?
Yeah, I would. I think that's absolutely right, and I don't want I don't want this to be a critique, but just a statement of reality. What happened with the Innovation Center was, and it continues to do fabulous work, and they've done a great job. But we did push it through the established policy process, and so we ended up. The way it came out, we ended up using the clearance process and all that implies on the innovation programs. And I think frankly, David Cutler at one point made a recommendation that there should be a parallel track, that there should be to the standard policy-making process, which is months and months and months and compromises in the making, right, and adjustments, and by definition almost is the epitome of what can't go quick generally. And again, it needs to be because everything that's done there is so important. But it may be one consideration for a president would be to think about whether or not they should take that kind of alternative pathway and think about creating a more nimble approach to some of the payment models and adjustments, minor adjustments there too, to facilitate what Peter's described as the original intent. It's not a simple question, but it's something to put on the table for the new administration.
Yeah, I think it's also a question about the relative role, again, of the public and private sector. The private sector can kind of try a bunch of stuff, start small, scale fast. It's just different. So that's one issue. But having said that, there is an effort that CMS has supported right now called the Healthcare Payment Learning and Action Network. It's a public and private collaborative that is designed to address, particularly around payment reform, the exact question that was laid out, like how do we learn, what can we learn from implementation? It's actually co-chaired by Mark McClellan and Mark Smith, and there is a piece of it that's focused specifically on implementation. How can we learn, first, can we even call a bundled payment? Do we actually mean the same thing? So there's some definitional pieces, but also focus squarely on implementation research, and I think that's very promising as well.
I feel compelled to defend the congressional branch of government, albeit briefly. It's a slightly different crowd today. But I don't disagree with anything that's been said, but recognize also that there are times, and I use the PACE program as an example, where the Congress proceeds, as we did, to create the PACE demonstration all those many years ago when I was still on the committee. And it took forever to get data that allowed us to make a decision as to whether or not to make it permanent. Now, part of that is the political machinations that occur. But coming to an end point, that is, this is the question, this is the test, this is the result, is sometimes challenging for an administration. And so I would simply say that the political process is a difficult one. It is polarized, but the time needed to essentially inform the members about these issues is important, and making the data available that allow us to evaluate whether it's a success or not, and the clarity of the data can also have a huge impact on people that care deeply about these programs. So I think there are issues on both sides, I would simply suggest.
I agree, and I think I was talking with Mike Chernow earlier about this, but there is this. We constantly confronted this question of how you go about developing applicable and adequate knowledge. And I just would say to our friends at NIH, it would be great if you could become more involved with Mike and other people who are doing kind of formative evaluations and try and look for ways of going at knowledge creation that's more rapid and nimble than what we've done traditionally.
Able to do.
Yeah.
To my left.
My name is Ruth Lou. I'm a nurse midwife and anthropologist. In 1975, I established through the not-for-profit for which I worked in New York City the first freestanding birth center in the country. It was established because there were so many young pregnant people who didn't want to go to the hospital. They thought they were sectioned too often, their families were not permitted there, and so forth and so on. So from the people, I learned what it was they wanted, and we gave it to them. And then in 1988, because we did not see low-income families on 92nd Street between Madison and Park, I won't explain why. We did another one in the South Bronx. I knew that we could make the outcomes better for those folks that were mostly of Puerto Rican or African American background, but I did not see the empowerment factor. And there is a large empowerment factor when you connect to the community. And I agree with the gentleman who said about that. Because of all this, I received a MacArthur fellowship. I'm really a girl, but I got a fellowship. And so I came down to Washington because the worst outcomes in the whole country were here in our nation's capital. And that had been on my conscience for a long, long time. We have been able to reduce preterm birth by 2/3, low birth weight by 3/4, and cesarean section by 2/3. The Urban Institute has studied us and studied us on the cost issue, and they project that if all Medicaid births in this country, of which there are about 2 million a year, were managed on our model, and it includes good hospital backup and medical consultation and so forth, it could save $2 billion a year. Do you think that makes me friends? Not at all, not at all. And when we save that kind of money, who gets it? Medicaid managed care. So we haven't talked much about Medicaid, but I would like your advice on how to get that changed. I also need to mention that Dr. Gilfillan was out and saw our unit, which includes a birth center, a lot of social supports, and early childhood education, and all together in the same building. And it was when he was there at CMMI that the Strong Start initiative started, and I think the results of that are going to be coming in probably in June of next year.
Thank you.
What can we do about,
Ruth,
Medicaid?
You know, I think your story is a great example of what I said in the outset of my remarks, where I said, you know, our challenge, in many areas, we actually know a best practice, we just haven't scaled and spread it. And I think birth centers are one of them. This Learning in Action Network I referenced a moment ago, there was we actually specified a maternity bundled payment program as part of that. And if you looked at kind of promising practices, that was identified, but we also identified that about 2% of all births, maybe a little less, are in freestanding birth centers in the US. But good news is, and maybe this is just a question of timing, but this now activity has now been picked up, and there is a collaborative among the Medicaid directors to basically see if this can be spread in Medicaid. And I agree with you, there's a lot of innovation possible in Medicaid, and in this area in particular, because Medicaid pays for about half, and maybe even over half of all the births in the US. So things like that, group prenatal care, there are lots of promising practices that we need to basically be sure they're scale and spread to meet the needs of the population.
Rick, I'm going to ask you, I'm anxious to get through, if I may.
Brad.
To my right.
Hi, Neil Halfin from UCLA. This is a question mostly for Peter Orszag. In thinking forward where our healthcare system needs to move towards from a healthcare system really towards a health system and focus more on prevention of population health. And you raised the issues of inequality that we're seeing as this sort of new frontier. I'm reflecting back to several of the OMB circulars that you issued about place-based initiatives during the Obama administration that were looking at issues in inequity. And as we think forward, I've heard nothing here discussed about what the next generation of healthcare value producing organizations that are really going to begin to link what happens in communities with the healthcare system. We haven't heard anything yet about accountable communities for health and how we move forward. You've talked about making patients sticky. How do we make the healthcare system more sticky in terms of how it connects these two parts of the system together so that we actually have a health system? And what's the economic, the macroeconomics rather than the microeconomics of payment that will allow that to happen?
Well, look, I think this is not just in healthcare, by the way, but in healthcare and in other policy areas. Since those circulars were issued, the research is increasingly showing place-based as opposed to individual-based makes a huge difference. And again, it's not just in healthcare, but too much of federal policy has been person-focused instead of place-focused, and we're learning that that just doesn't really work very well. You need to focus on building a healthy community and not just one single individual. So there's sometimes a little bit of tension. We want to be as personalized as possible, but we have to realize that that is happening in a community. The problem becomes exactly how to get there, which is your question. I don't have a magic bullet solution for you. I do think the first step is recognition, and I'm still amazed, not just in healthcare, but writ large, at how much policy discussion occurs that just kind of ignores the community environment. Even on, by the way, we're talking about risk adjustment earlier. Adding the socioeconomic variables in the community also is a big, additional explanatory boost, which just makes the point. So I don't have a solution for you beyond just doing what you just did, which is to highlight the issue and slowly move towards policies that reflect it. I don't have a single solution for you, unfortunately.
I'm going to apologize to the remaining folks standing, but encourage you to grab our speakers during the break. But let me, please join me in thanking a remarkable panel. Thank you, gentlemen.
Yes, and let's also thank the remarkable moderator for a great job.
Yeah.
Congressional defender.